So now we will be talking about this new topic, that is alcohol dependence and withdrawal and its management. I'm Dr. Agila C, Assistant Professor, Department of Psychiatry, Sri Lakshmarana Institute of Medical Science, Puducherry and Bangalore, Chennai. So, good morning, one and all. Let's go to the slides. Okay, so introduction. What is alcohol now? Why it is studied so much? Because alcohol is basically a CNS suppressant, and it has got very deteriorating effects on brain once being dependent on it. But before that, there are ways to prevent it and prevent the dependence, and also catch the person at the right time, right moment, give them support and psychotherapy and proper de-addiction setup. Everything can bring the patient out of all the hazardous effects of alcohol. So alcohol consumption is usually associated with social and psychological and physical components. Now that is why it is most widely studied and discussed, and it's always a huge uh, talk of stigma in the society. Alcohol dependence, previously known as alcoholism, but this system is derogatory, so it has been dropped out nowadays. So this is the formula. C2H5OH are the derivatives of hydrocarbons. Now, ethyl alcohol is also known as ethanol, which is the most common form. It is metabolized in human body by alcohol dehydrogenase and then by aldehyde dehydrogenase. Now, alcohol units, the amount of alcohol in drink is measured in units. Now, 1 unit contains 8 grams of alcohol. Now, 1 unit is equal to 10 ml of 1 liter of 1% alcohol. Number of units is equal to volume in liter into percentage of alcohol. For example, a 250 ml of wine with 10% alcohol has 2.5 units. So you can do the calculation here. It's 250 into 10 divided by 1000. So that sums up to 2.5 units. Now here we have 1 unit. Like these are the equivalents. Like you see, we have normal beer, 284 ml, 4%. Then small glass of red wine. Actually, this is red wine, 12.5%. Strong beer, half pint is 284 ml, 6.5%. Strong beer, large bottle can, 440 ml, 6.5%. Bottle of wine, 750 ml, 12.5%. Bottle of spirit, 750 ml, 40%. Single spirit shot, 25 ml, that is 40%. Now you can see how it is increasing. Now that red wine is 12.5, but beer, strong beer, normal beer, any sort of beer is going to be 6.5. But a bottle of spirits, single spirit shot, alcopops bottle, these are all on the higher side. Then normal beer, again, large bottle contains only 4.5%. Large glass of wine also consists only of 12.5%. So the government advises alcohol consumption should not be regularly exceeded. In men, it's only 3 to 4 units maximum daily allowed. Women, it's 2 to 3 units daily allowed. Now, alcohol dependence syndrome, a cluster of physiological, behavioral, and cognitive phenomenon in which the use of substance or a class of substance takes on a much higher priority for a given individual than other behaviors that once had great value. So it is basically physiological, behavioral, and cognitive phenomena. Like all three are involved. So that is why there are severe pathological features in the body, like for example, liver cirrhosis, behavioral. There could be even behavioral disturbances, and also it could lead to problems like psychological problems. like alcohol-induced psychosis and cognitive phenomena in the late stage. Even alcohol-induced neurocognitive disorders are very common these days. So this is the ICD-10 criteria. Here we have uh, a definite diagnosis of dependence usually being made only three or more. Like for example, number one will be a strong desire or a sense of compulsion to take the substance, difficulties in controlling, physiological withdrawal state, that is, withdrawal symptoms like tremors of hands, hallucinations, seizures, that is withdrawal seizure, also known as trumpets or delirium tremens, and then evidence of tolerance, such that increased dose of psychoactive substance are required in order to achieve the original effect produced by a lower dose. So it's basically these six. And neglect of alternative pleasure, like they would have neglected all the interests, like all the social activities and all the different entertainments and family outings. Everything will be sacrificed for the sake of control. And persisting in substance abuse despite clearly they are aware, like they will be having hazardous effects or harmful consequences. They know psychologically they can be affected, they know everything, but still they pursue it. Then we have criteria for alcohol dependence, that is narrowing of the drinking repertoire. This is by Edward and Boss. Priority of drinking over other activities, tolerance of effects of alcohol, repeated withdrawal symptoms, relief of withdrawal symptoms by further drinking, subjective compulsion to drink, reinstatement of drinking behavior after abstinence. Now, these are the etiological factors. That is, from first, we have biological factors. That is, genetic vulnerability, comorbid psychiatric or personality disorder, comorbid medical disorder, reinforcing effects of drug, withdrawal effects and craving, biochemical factors. Now, psychological factors, we have curiosity, general rebelliousness. This actually this can be attributed to conduct disorder, which starts at the age of 13 or even less, 11, 10 maybe. So even before the personality develops, that is antisocial we are looking at. But here these are the general psychological factors: early initiation, poor impulse control, sensation seeking, low self-esteem, psychological stress. Mostly psychological always goes hand in hand with social, that is father, grandfather, how the society is perceiving alcohol as concerns regarding personal autonomy, stress, trauma, loss, relief from the take, escape from reality, lack of interest. The social factors, like I said it's always a biopsychosocial approach. So here we have social factors like peer pressure, modeling, ease of availability, strictness of drug law, enforcement, intrafamilial conflicts, religious reasons, poor social familial support, perceived distance within the family, permissive social attitudes, and rapid urbanization. So these could be like out of which you can focus mainly on the intrafamilial conflicts and permissive social attitudes. Like these two are, according to the social factors, it's one of the most basics, basics of, it's like a basement, it's like laying basement for alcohol dependence. Now, this intrafamilial conflicts, like father mother fight, then we have the permissive social attitudes. Like in certain countries, it's so fine, it's so legal, the whole family gets drunk. So those kind of permissive social attitudes and intrafamilial conflicts. So these basically lay the foundation, and always, almost most of the cases, it's always because of the peer pressure. Now, peer pressure, if I have to say, it's always the starting point of any alcohol dependence. So peer pressure is one such thing. And these are the types of alcohol dependence, that is alpha, excessive drinking, ability to abstain. See, now we are going into different types of drinking pattern, that is dependence pattern. So So it's basically a drinking pattern, we can say. There may be excessive drinking, but they have ability to abstain. Beta, there is excessive drinking with complications, but no dependence. Now, this we can notice around the obituary. If you can see, there may be excessive drinking with complications, but there won't be. There are many people like this, who get admitted in our indoor setup, but they don't have dependence. It's just on the bordering on the harmful use or hazardous use, but it's always excessive drinking with some or the other complication. Now, gamma and malignant alcoholism is this gamma type, which is also known as malignant alcoholism, is physical and psychological dependence, inability to abstain. Now, delta will be inability to abstain, minimal social destruction. Now, epsilon will be dysomania, that is pre-drinking. Now, this epsilon is like sort of emotional drinking, which is usually seen in females, like epsilon. And delta, you can remember, inability to abstain with minimal social disruption. There is not much of social disruption. Now, the gamma is the most dangerous. Like you can see, there is both physical and psychological dependence. Now, cloning this classification, here we have type 1 and type 2. Here we have that is synonym, that is male limited and male limited. Gender is both sexes. Type 2 is mostly male. This age of onset is more than 25 years, less than 25 years. And here we have age of onset more than 20. Okay, etiological factors, genetic and strong environmental influences, genetic and limited environmental influences, family history may be positive, always positive, loss of control present, absent, other features, psychological dependence and guilt, for drinking followed by aggressive behavior, spontaneous alcohol seeking, premorbid personality, harm avoidance. Basically, these people are novelty seeking. Now, if you see, these people are very much like in the problematic category. Like type 2 is more dangerous, and type 2 is more prone for all the problems, basically, like the aggressive behavior. Usually, there is a positive family history. The father is drinking, the grandfather is drinking, or the society or the peer pressure, or the group of friends is having. So, type 2 is always like, leading to all this conduct and antisocial personality disorder. Acute intoxication and transient condition following the administration of alcohol. Now, if you can see, there is a disturbance in the level of consciousness, cognition, perception, affective behavior, and other psychological functions and response. Now, acute intoxication is a brief period of excitation. Generalized CNS depression occurs. Then we have increased intoxication. Then we have increased reaction time, slow thinking, distractibility, poor motor control. Like you can see, say hello is like hello, like that. So dysarthria, ataxia, and coordination occurs. Then we have progressive loss of control, defined disinhibited behavior. Then there is pathological intoxication, small dose of alcohol producing intoxication, amnesia. That is, we can see amnesia or blackouts basically. So they don't remember what happened. So here we have the body fluid alcohol levels. Now these are very important for any person in the UG or PG, or for even faculty level or anywhere. Like, we just need to be aware how much we take and what is happening inside our body. Like as medicals, we are so much exposed to all sorts of like parties or conferences everywhere. Alcohol is deep in. So you should at least be aware, like what effect, or at least you can just guess by yourself by remembering such things, like if euphoria and gregariousness and coordination is there, then blood alcohol levels will be 50 to 100. And here we have slurred speech, ataxia, blood mild mood, drowsiness, nausea at 100 to 200. This is for sporadic drinkers. Now, chronic tolerant drinkers, they know what they are doing and they know what is happening. But this is for the sporadic drinkers. And lethargy, combativeness, stupor, impotence, speech, and vomiting at 200 to 300, coma 300 to 400, and more than 500 will be kept. Now, chronic tolerant drinkers, minimal or no effect, that is 50 to 100, where we will be the normal sporadic drinkers, will be having like 50 to 100 level, and at that time they won't be having any effect because of the tolerance they would have developed over the years of time. And then 100 to 200 will be sobriety or coordination euphoria. Then 200 to 300 mild emotional and motor changes, 300 to 400 drowsiness, more than 500 lethargy, stupor, and coma. So they are actually one step behind than the normal population, because by 500 these people would be dead, but by 500 still they would be in stupor stage or coma stage or just be lethargic. So you can see the difference. Now that's how important tolerance is, which is one of the main factors for dependence. Alcohol withdrawal syndrome is a cluster of symptoms we'll be seeing one by one. So alcohol withdrawal syndrome, that is tremors, nausea, vomiting, weakness, irritability, insomnia, anxiety, delirium tremens, alcohol withdrawal seizure, and alcoholic hallucinosis. Now we can see time by time. Like first 6 hours, we have tremors, nausea, vomiting, autonomic hyperactivity, where there is increased heart rate, increased temperature, increased blood pressure, and then there is weakness, irritability, insomnia, anxiety within the first 12 hours. First 6 hours, then 12 hours, then 12 to 24 hours, we have alcoholic hallucinosis. Then 24 to 48, we have alcoholic seizures. Then we have the delirium tremens from 48 to 72 hours. So psychological, if you see on this hand, anxiety, restlessness, irritability, insomnia, headache, there could be poor concentration, social isolation. Physical, we have sweating, heart palpitations, muscle tension, difficulty in breathing, tremors, and nausea and vomiting. So like I mentioned, you can see 6 to 12 hours, there will be all these autonomic hyperactivity, tremors and stuff. 6 to 48 actually, that is what 24 to 48 we can keep for seizures, because we have seen cases who had seizures in the first 6 hours itself. So that is why they have kept 6 to 48 hours. And we have 48 to 72 hours for hallucinosis and 3 to 5 days. This is actually 48 to 72 for delirium, and then 12 to 24 or 24 to 48 will be for hallucinations. So basically the duration usually for delirium tremens will be only days, not like in weeks. So it is usually resolving in days. Delirium tremens is something, if you don't treat, there is 20% mortality. It occurs within 3 to 4 days of complete significant abstinence. It's a short course, recovery is within 3 to 7 days. Now, delirium tremens, the pathophysiology here is basically there is increase, alcohol increases gamma. Basically, alcohol is the same as suppressant, and it increases gamma, that is the inhibitory effect, and decreases glutamate, which is the excitatory effect. Now, glutamate, when it decreases, the excitation of the brain also goes down, while gamma, when it increases, the inhibition of the brain goes up. Now, that is how CNS depression occurs. Now, what happens to this when you suddenly stop consuming alcohol? There is abrupt cessation and brain hyperexcitability because receptors are no longer inhibited. And repeated alcohol withdrawal symptoms more severe, there is kindling effect. Long-term changes in the neurons after repeated detoxifications. Now, what happens is the symptoms become more severe. That is, there's always a process called kindling. Kindling is the hyperexcitability of the neurons. So it becomes more severe with every detox, right? So here, because of this, like you can see, when alcohol is suddenly stopped, the consumption is suddenly stopped, there is hyperexcitability, and because the receptors are no longer inhibited by GABA, so glutamate is increasing. Glutamate is an excitatory neurotransmitter. So delirium tremens, if you see, now it's an acute organic brain syndrome. It is basically a medical condition, but here we have alcohol withdrawal delirium, which is due to alcohol, and since psychiatrists manage delirium tremens. This clouding of consciousness with disorientation, poor attention span and distractibility, visual and tactile hallucinations, psychomotor agitation, and ataxia. So, among hallucinations, there could be more of tactile hallucinations because there might be bed-picking behavior, and they'll try to pull out the ID lines thinking that those are some unusual perceptual disturbances on the body. Now, delirium tremens, here we have the autonomic disturbances, that is tachycardia, fever, basically autonomic hyperactivity also can be there, pupillary dilatation, insomnia, dehydration, and if untreated, like I mentioned, it's untreated, it's 10 to 20% actually, 5 to 10% may suffer all these collapse and infection hypothermia, but 10 to 20% is the stats for death if delirium tremens is untreated. Alcohol seizures, it's also known as fits. A generalized tonic-clonic seizure in person, and onset is within 12 to 48 hours. As we see, multiple seizures are more common. Status epilepticus may occur, but so far we have seen only multiple episodes of GTCs, and which are usually controlled by lorazepam. 30% delirium tremens follows. So alcoholic hallucinosis, again, they're mentioning here, it is like hallucinations, it can be partial or complete in the absence. 2% of patients generally report this. Now here we have the complications of alcohol dependence. Here we have medical complications, that is in GA, it's a liver. Now why we have highlighted this is because fatty liver cirrhosis, hepatitis, and CA, that is of liver and liver failure, are the most common. Then we have reflux, which esophagitis, varices, Mallory syndrome, and also carcinoma. In stomach, we have gastritis, eclohydria, peptic ulcer. Now you can see the most common will start from here: esophagus, stomach, intestine, pancreas, and liver. But the most dangerous will be here, and also this one, pancreas, acute pancreatitis, and chronic and relapsing. And of course, patient may die even due to malabsorption syndrome because it is like protein losing enteropathy, which is a very, very common thing. And in liver, we have this almost invariably in every person's USG abdomen and pelvis, ultrasound abdomen and pelvis of an alcohol dependent person, you will find fatty liver. It is in either grade 1, grade 2, grade 3, but you will find it. So here we have also symptoms and signs and symptoms of portal hypertension. Like if you can see, we have number 1, we have Mallory syndrome or esophageal varices. Then we have caput medusae. Then we have we may encounter cases of hemorrhoids and hematochezia. These are all very common. And here we have the other conditions, like we go into one by one. Wernicke's now. Wernicke's is acute reaction to severe depletion in time. Severe depletion in time results from damage to the mammary bodies, but also medial nuclear thalamus and adjacent areas of periventricular gray area. Now, onset is after a period of persistent vomiting. This is hyperemia, petechial hemorrhages, and astrocytic proliferation are the findings. And one case is usually due to B1 deficiency. Now, these are the ocular signs. We have nystagmus, ophthalmoplegia. It's actually internuclear ophthalmoplegia. Then we have bilateral external rectus paralysis, pupillary irregularities. These alone are on the ocular signs because ocular signs are not to be neglected, not to be ignored in a case of Wernicke's encephalopathy. So nystagmus, ophthalmoplegia, bilateral external rectus paralysis, pupillary irregularities, retinal hemorrhages, papilledema, and vision impairment. Now, these are the higher mental function disturbances in Wernicke's. We usually say it as GOA, that is global confusion. Then we have ataxia. Then we have ophthalmoplegia, like ophthalmoplegia and ataxia. So disorientation, confusion, peace and memory disturbance, poor attention, distractibility, apathy, and ataxia. Now, Korsakoff psychosis, untreated thiamine deficiency, secondary to chronic alcohol use, organic amnestic syndrome, gross memory disturbance with confabulation and loss of insight. Now, pathological lesion, that is dorsomedial nuclear thalamus, mammillary bodies, this we've already studied. These are the pathological lesions. Now, this is one interesting syndrome or a disease called Marcia-Fava. Now, this was first noted in Italian people who are dependent on alcohol, especially when they have this type of addiction towards even rice, not rice exactly, it's white wine. Sorry. So, white wine basically they have increased consumption of white wine and cooking and sort of things. So somewhat they found a correlation that over a prolonged period, not only just white wine, just any sort of alcohol content, beverages, or many studies correlated with white wine. That doesn't mean white wine is giving the exact cause, like it is the exact etiology of the disease, but there is a correlation in Italian studies. So here we have, there is corpus callosal atrophy. There is demyelination of corpus callosum. We have seen one case of Marcia-Fava so far, and there is demyelination of optic tracts, cerebellar peduncle, and it is usually the clinical features are like disorientation, epilepsy, ataxia, dysarthria, hallucinations, spastic limb paralysis, deterioration of personality and intellectual function. Now, this looks more like a neurocognitive disorder picture, but it can happen at any age. It doesn't have to be like neurocognitive disorder. The age factor matters here. A young person may also present with such features. Now, we should have this in mind and look for neuroimaging correlates. So, miscellaneous, these are the miscellaneous where we have you can see acne rosacea, palmar erythema, like we already discussed all the potent hypertension signs, cardiomyopathy, wet beriberi and dry beriberi as well. Wet beriberi is cardiac beriberi, alcoholic myopathy, and accidental hypothermia and risk of CAD. Now, these are all the other, among this we have one thing that is to be discussed, that is infertility. Now, there are many patients that we have to complain often of erectile dysfunction and also loss of libido because of the decreased testosterone levels. And yes, the next condition is pellagra, where there are 4 Ds, that is dermatitis, delirium, dementia, and then last comes death. So here we have alcohol withdrawal assessment. Here history taking is most important. Also breath analyzer. Then PTINR, of course, LFT, CBC, your routine. And here we have the management. We apply 2 scales mostly on the regular basis, like SIVA AR2, Clinical Institute Withdrawal Assessment of Alcohol, scale revised. And we have short alcohol withdrawal scale 3, are both 10-item scales which can be completed in around 5 minutes basically. So we always apply this to choose a regimen for the detox basically. Once the detox is over, then we go for the addiction. It's done in 2 steps. just keep in reserve preparation for detoxification. Here we have the management, that is use of benzodiazepines and alcohol withdrawal. Now here we have that is typically given for 7 days. Now here it's like you have it for fluoride oxide, that is the benzodiazepine choice. But once there is a liver compensation, you cannot do fluoride oxide. The ideal option is lorazepam because fluoride oxide is metabolized by liver. Then shorter acting benzodiazepines such as lorazepam, most commonly oxazepam we don't use in a compensated liver disease. Then longer acting may be helpful, definitely. It's not maybe, it's definitely helpful in preventing seizures and delirium. And inpatients should be withdrawn over 2 to 3 weeks. We usually try within 1 week. That is our target. Then dosing regimens are associated with fixed dose. Now, fixed dose is something we fix the dose. Okay, this is the dose we are giving. For mild, it is usually a very small dose, like 25, 50, or 100 milligram of fluoride. For moderate, it is usually a larger dose. Now, larger dose we usually give more than 100. Now, that will be a larger dose. But for a milder dose, it will be less than 100. That is of fluoride oxide. Usually, the treatment should be adequate within 5 to 7 days. Now, management with severe alcohol dependence requires even larger doses of fluoride oxide. Intensive daily monitoring is required. So, this is the same. And fixed dose. Fixed dose is first 24 to 48 hours. Like you fix the dose, for example, in our setup, we commonly use, okay, we get the USG reports and there is some compensation of liver. We just put them on lorazepam 8 mg. Now, after applying SEIZURES and SAWs, if the scores are very high, then definitely we can go to 16 mg. So that doesn't matter. That is to prevent the delirium tremens. Now, here we have the flexible regimen. Maybe it may need to be prolonged beyond the first 24 hours. So don't undertreat or overtreat is the key. Now here we have the front loading. Front loading is initial loading of medication as the 20 or 100 fluoride oxide is given. Then initial loading is given, after which the further doses are between every 1.5 to 2 hours until light sedation is achieved. Cessation once light sedation is achieved. Then monitor the patient every 2 hours. Now this is the front loading. Now this also we have done. We first give the good dose, and then that is 100 mg fluoride oxide or diazepam 20, or lorazepam we can go to 4 to 8 mg. Now with this we'll wait, and then with every 2 hours, every 2 hours we 2 mg every fluorazepam or 10 mg of fluoride oxide or 5 mg of diazepam, but 5 mg of diazepam is usually higher. So better to stick with lorazepam and fluoride oxide. So this is the management. And for severe dependence, it's the first 24 hours, that is day 1. First dose immediately start after admission. The dose of fluoride oxide should be within the range of 5 to 50, like I said. And subsequent dose should be administered during the first 24 hours. And 5 to 40 will cover almost all circumstances. But in severe dependence, you can go more than 100, and there are cases we have been up to 200. So that was a severe dependence, and doses about 250 is not prescribed usually, but we can go up till 100, or if it is very, very severe, and we can rapidly down titrate. So it is called baseline dose, then it is used to calculate the subsequent doses, reducing regimen. So day 2 to 5 fluoride oxide in divided doses 4 times daily. So this is how it is done. And observation and administration. Here each set of observation consists of alcohol withdrawal, SEIZURES, AR, and SAWs, and clinical observation, blood pressure, heart rate, pulse oximeter, and breath analyzer. Now, observation should be recorded during the admission procedure immediately after arrival throughout the first 24 hours, approximately every 1 to 2 hours. Frequency will also depend on the severity of withdrawal. Twice daily observation from day 2 to 6. Now we keep doing this almost every 6 hours regularly because we have a 24-hour intern in the ward and he does all the monitoring. And if something goes wrong, immediately the postgraduate is called upon or the consultant is called upon. So, this is very much followed in our setup. If the patient is asleep, don't wake them up. And if the patient suffers hallucination, then increase the dose. Like assisted withdrawal in medically compromised patients, that is, like I said, better option would be lorazepam as soon as we almost always get the USG abdomen, that is a sonography of abdomen and pelvis done so that we get the liver status, we get to see the grade of fatty liver or it is cirrhosis, whatever, whatever the liver status is, and soon that would help us. We do it on an OPD basis so that by the time the patient reaches the ward, we'll be getting the results, and by the time we'll be starting with the regimen we want and with the drug we want. So, of course, approximate equivalent dose of benzodiazepines are follows. This is very important. That is, diazepam 5 mg is equal to chlordiazepoxide 15 mg is equal to oxazepam 15 mg is equal to lorazepam. Now, oxazepam is also useful in patients with chronic respiratory disease. And majority of dependent people are smokers, so always use a withdrawal assessment scale as well. Now, you can start on you can definitely have to start a patient on injection timing because there is usually a fluid loss in the body and the patient might be dehydrated. So when we give, suppose if we want to give a fluid, say we are giving glucose, and what happens in the brain is there is glycolysis that is going to take place. Now, glycolysis, there is a step in which thiamine pyrophosphate is a cofactor. Now, already thiamine is depleted. Once on top of that, if we are going to administer glucose, that is 5T or DNS or simple plain DNS water, still there would be much more depletion of thiamine, which would precipitate Wernicke's encephalopathy. So always remember to always put in a ampoule of thiamine or multivitamin ampoule into the DNS before administering any fluid. So always be careful with that. Now, because these are the pathways, like in the presence of ATP, it is converted into thiamine pyrophosphate, which functions as a carbohydrate metabolism. That's what I said basically right now. So it is a cofactor in glycolysis as a coenzyme in the decarboxylation of pyruvic and alpha ketoglutarate acids. So it's actually involvement of three cycles. Now, one is the glycolysis, the other is the pentose phosphate pathway, and the other one is the Krebs cycle. So, all these three are interconnected with thiamine pyrophosphate. So, that is why we have to be very careful while administering any fluid for that matter. Now, possible mechanisms, you can see the thiamine deficiency is inadequate intake of these, decreased activation of thiamine to thiamine pyrophosphate, reduced hepatic storage of thiamine up to 73%, inhibition of intestinal thiamine transport due to decreased enzyme activity, impairment of thiamine absorption due to ethanol-related nutritional deficiencies. Now, prophylactic use of thiamine, like you can see, 300 mg daily during drug-assisted alcohol withdrawal and periods of high alcohol intake. Now, 300 to 500, we can keep it as a standard. And usually at least 4 ampoules, that is complex vitamin 3 times daily for 2 days we used to give. And you can see IV infusion over 30 minutes in 100 ml NS of 100 ml, that is sodium chloride. Oral thiamine 100 mg 3 times daily for 3 to 6 months. That is, we have a good brand called TDS we can have. Now, prophylactically, we have this IM, IV, like I said, usually when the person comes to casualty, we have a tendency to start, okay, let's start DNS, but that is not the way it should be. Always we have to keep counting in our heads that to put the ampoule in the DNS. Just put an ampoule of the complex or thiamine, anything that is available. Just put it in and then start. So always remember now that would be precipitating vernices. So this is like a prophylactic management. Now seizure prophylaxis, we need not use any carbamazepine or sodium sulfate or any antiepileptics. Now this is very particular here. If you can see, it's with untreated epilepsy. Epilepsy is as such a disorder. Like it is a disease by itself, and it is not. And seizure is just one episode of epilepsy. So seizure is basically due to alcohol. So obviously, which is the most effective here will be the benzodiazepines, because alcohol is equivalent to benzodiazepine, because both act by GABA activation. So here it is like the best option would be a benzodiazepine, but here you can see very carefully what it is written. It's with untreated epilepsy. The person is already an epileptic. So in that case, you can definitely start. So seizure management, alcohol-related seizure usually occurs within 12 hours after cessation, and rarely it goes beyond 48 hours. And we have not seen a case of status epilepticus due to alcohol withdrawal, but there can be cases who person who's already epileptic can go into a status, and lorazepam injection stored in the fridge to be the second dose after 15 minutes if required. Now, if seizing is prolonged, then status epilepsy, senior medical advice. Usually, we don't have to manage it in our ward, psychiatric ward. Always, if there is prolonged seizure, then we need not wait and we have to send the patient immediately to the medical ward or medical ICU setting. So, lorazepam 2 to 4 mg IV is a single dose. That is, it can be diluted 1:1 with water for injection before administration. Now, delirium tremens, again, usually lorazepam will be a better option. If patient is not settling after 3 doses of fluodiazepam 40 mg, then we can consider escalation to lorazepam, that is 2 to 4 mg, oral, IM or IV. Now, IV would be a better option. Repeat if required of 2 doses at 15 minutes interval. Always consider oral before the IM group. Absorption from the injection site is considerably slower if the intramuscular route is used. Like I said, IV is the better option. Now, using haloperidol can be used for perceptual disturbances, like the patient has got florid hallucinations, and patient is very much agitated and extremely disturbed, and maybe having some parasocial behavior. It is best to always sedate the patient with IM haloperidol. Usually, we prefer IM over IV, because IV haloperidol, that is intravenous haloperidol injection, might have dangers of sudden cardiac death, so we need to be a little bit careful here. So here we have naltrexone as one of the, now coming on to the anti-craving agents. Now we have acamprosate. Now acamprosate is one of the anti-craving. It is an NMDA antagonist. Now here it is like the dosage is, if it is the person's weight is less than 60 kg, then the dosing would be 666 mg twice daily. That is 333 in the morning and 333 in the night. That is, I'm sorry, 666 twice daily. But if it is more than 60 kg, then it is going to be in the morning 666, afternoon, and the night. Now you can see how they dose beautifully. Like for the patient being less than 60, more than 60, we have 3 days. Now it's less than 60, we can keep it as 666 in the morning, 333 in the midday, and 333 in the night. Now, naltrexone, usually we have seen patients who have had diarrhea, and there might be patients who want to stop it because of these unpleasant GI disturbances, but still we can assure them or we can give them some antidiarrheal agents or any other drug that could help symptomatically and should motivate them. So not naltrexone, I'm talking about acamprosate. No, naltrexone is a opioid receptor antagonist. Now this is FDA approved, and it is usually we put the patient on 50 mg. They tolerate very well. Hepatotoxicity has been discussed with higher doses, so it is to be avoided in hypertension. Now disulfiram is an anti-abuse. It's a deterrent. It's not an anti-craving. Always remember it's a deterrent. So we know the mechanism of action. We know it's the enzyme aldehyde dehydrogenase. First, alcohol is converted to aldehyde by aldehyde dehydrogenase, aldehyde to acetic acid by acetic acid dehydrogenase. So first we have aldehyde dehydrogenase. Now, aldehyde dehydrogenase, it is actually the enzyme which is inhibited by disulfiram. And I'm sorry for that. I said it a little bit wrong. It is aldehyde to acetic acid by aldehyde dehydrogenase. So disulfiram inhibits aldehyde dehydrogenase. Now, contraindications are cardiac failure, coronary artery disease, history of vascular disease, pregnancy, breastfeeding, um, liver disease, and peripheral neuropathy. Now, baclofen is one good agent we've got in the recent days. GABA receptor agonist and muscle relaxant. The anti-craving and anti-reward effects of baclofen appear to relate to its agonistic action, the GABA B receptors in the VTA areas. Again, VTA is a mental tegmental area of the meso, that is the midbrain. So doses are 10 mg days. And alcohol-induced psychotic disorders, alcohol-induced mood disorders, alcohol-induced. These are the common disorders that are related to alcohol. Then we have alcohol-induced anxiety, 80%. Then alcohol-induced amnestic disorder, and alcohol-induced sleep disorder. A prognosis, no antisocial PD, then it is a good prognosis. Close family, contact, life stability, with job, good prognosis. Full course of initial rehabilitation, good prognosis. Now we have Alcoholic Anonymous, where we have a group of people who have been dependent and now are in abstinence, come along together, sit in a circle and discuss their entire story. Now that's a very good discussion. It's like a group therapy, and there can be a help for this Alcoholic Anonymous, usually a psychologist. Now counseling to motivate for abstinence. Thank you so much. Thank you.